So first we'll have a debate for the consideration of a suburethral sling, followed by the debate to not use a sling but to go directly to an artificial urinary sphincter.
For your debaters.
My debaters? For the suburethral sling, Dr. Tobis. Yep. And then for the sphincter, Dr. Kirk Roth.
Ladies and gentlemen, I must apologize. I know you all drove a long way expecting a debate worthy of your time and your intelligence. However, I must inform you that there is no debate to be found here. Instead, what you will find is a good old-fashioned shellacking from my opponent, as I tear apart his ridiculous dog and pony show. What you will likely see from my esteemed colleague over here is a lot of smoke and mirror trickery, clouding your mind with fancy pants words like gold standard, as he attempts to convince you that this patient deserves the medieval torture device, otherwise known as an artificial urinary sphincter. But before I sink my opponent's proverbial battleship, let me show you why the male sling is the only reasonable option for this patient. If my friend over here is going to invoke the guidelines set forth in the last AUA update in 2007, or the International Consensus Conference on Incontinence in 2005, well, those regard, frankly, outdated data from outdated slings. That's like suggesting the original iPhone remains the gold standard just because you haven't been to a Best Buy in the last 5 years. Therefore, when I refer to the male sling, I will be discussing the advanced trans-operator male sling system. So let's talk about the data regarding the advanced sling. These data show cure and improvement rates of 75 to 82%. And the fine print in these success rates is that these trials were fairly unselective. In 2010, Bauer et al. Published their results of 137 patients with an overall success rate of 75% at 2 years. And almost 40% of these patients had severe incontinence requiring more than 6 pads per day, and 14% had received prior adjuvant radiotherapy. Cornu et al. Demonstrated similar results. In 136 patients with mean follow-up of almost 2 years, an improvement rate of 78% was achieved. 17% of these patients had received prior radiotherapy. In his recent review of slings, the good Dr. Hirschhorn identified that patients with severe incontinence or prior radiation had lower success rates. Therefore, in our index patient with only moderate incontinence and no history of radiation, we might expect a success rate even higher than those reported in the large trials. But the real reason this patient deserves a sling and not a sphincter is because we actually care about him. Just look at the complication profiles of these two procedures. The revision rate of the artificial sphincter is as high as 67% in Venn series, and in the Mayo Clinic experience, patients needed more than one surgery 38% of the time. Even the lowest reported revision rates are around 20%. But do you really want to tell this patient he has a 1 in 5 chance of having this procedure again? I mean, he's not rushing a fraternity so he can say, "Thank you, sir, may I have another?" Not only that, look at the problems these patients are getting. Erosion into the urethra in about 5%, infection 3%, mechanical failure 15%, and recurrent incontinence from urethral atrophy in up to 9%. Compare these disastrous complications to the male sling. In Bauer's 2010 report of 230 patients focused on complications, there were 2 cases requiring surgical management and 3 minor complications. In Cornu's 136 patients, 5 minor complications occurred. Not a single patient required surgical management. 0. In fact, the most common issue in each of these trials was transient postoperative urinary retention, all of which resolved with catheter drainage. So I ask you, why would anyone with only moderate incontinence agree to having their urethra used like a punching bag? So in summary, when our nice patient makes the correct choice of a male sling, he can expect success rates approaching those of an artificial sphincter without all the hassle of turning his perineum into the Korean demilitarized zone. Not to mention he'll be immediately dry with a sling, but have to wait 6 weeks to use his artificial sphincter. I guess that's like a nanosecond in Canada, I don't know. But perhaps my esteemed colleague over here could use an artificial sphincter. I believe he's had to change 5 or 6 of his own pads just listening to these arguments.
Let me get set up here with my original
iPhone. 5 minutes. So I'm going to be talking about the medieval torture device, the artificial urethral sphincter. And I'll march on with my dogs and ponies debate, the dogs being better patient outcomes and the ponies being durability studies that show that they're effective. We do know that the AUA guidelines or update series in 2009 did call this the sphincter the gold standard. A publication in the British Journal of Urology International published April 15th, 2011 on post-prostatectomy urinary incontinence review of surgical treatment options also called it the gold standard. And this is why. We can start with the older data, go to Campbell's. There they quote Fishman et al., Wilson et al., Petro et al., and are giving continence rates of 75 to 90%. Patient satisfaction rates of 85 to 95%. That's 95% despite some people do need revisions, of course. And then there's long-term good outcomes. There's durability data that's not there for the advanced sling. 2008 Journal of Urology, Kim et al. Long-term durability and functional outcomes among patients with artificial urethral sphincters from the University of Michigan. Did 124 patients. Over 8 years later, the amount of patients requiring no pads was 44%. The amount requiring 1 pad a day was 44%. 2 to 3 pads a day was 11%. The amount of people above that was 0. No one required 4 or more pads a day. And similar rates in terms of how the patients rated their quality of life. Journal of Urology, Lai et al. In 2007, 13-year data from Baylor College, and they had 270 patients, and they needed around 27% needed revision. And there are numbers that are lower than this. I think some of the reasons why some of the revision rates are thought of as so high is because the cuff is actually changing and it has become smaller. Elliott and Barrett published in the Journal of Urology a series with 323 patients, and during the middle of their follow-up, the sling started changing to narrow cuff, and the revision rate before was 42%, and the revision rate after was 17% of the people with the narrow cuff. So these are actually not that far off the studies looking at the advanced sling. So I'll throw away all of the other slings since you're arguing for advanced. Bayer et al. In European Urology 2009, they had the wonderful cure rate with the advanced sling of 52% after 12 months. And they had a failure rate of 25%, 16% of perineal pain. That'd be nice. With their satisfaction rates and revision rates less, but not that superior, Victor Nitti gave a talk where he was musing, why with 90% satisfaction rates with the urethral sphincter, why do we offer a sling? And he thought that the slings have become so popular because they're very industry-driven and they're very surgeon-driven. They're easier to do, they're fast, less expertise is required, and they're fun to put in. And if you need to do a revision, it's not quite as awful as a sphincter. So it's very surgeon-driven to put these in. They're easier to do. That doesn't necessarily mean that they're better to do, because the rates are worse. So if the big argument is revision rates, well, this is like saying, and I mean I agree with that, I'm going to tell my grandpa, because his kidneys are failing, that when he gets to end stage, he should choose an AV fistula procedure as opposed to a transplant, because there's a lot less complications with an AV fistula procedure. So clearly that is good logic. But, you know, it's not a big deal, because if we do sphincter and the people aren't happy, there has been a study in urology 2007 showing that 75% satisfaction rate after receiving an artificial urethral sphincter for salvage sling fistula.
If you are somehow not already convinced placing a sphincter in this patient would be a complete disaster, please consider 3 other issues. First, as our patient ages, he may become unable to operate a sphincter, thus simply returning his continence and waiting to become infected. Second, should our patient develop a bladder tumor or urinary stone, placement of an artificial sphincter would likely prevent appropriate endoscopic management. I dare my opponent to try to place a 24 French resectoscope through a urethra with an artificial sphincter and not perforate it. And finally, perhaps I can appeal to your wallets. Consider that the sphincter costs up to $10,000 more than twice that of the sling. Combine this with the revision rates of the sphincter, and you're talking about a lot of cold hard cash. So the choice is clear. The sling can be described as effective, safe, and cheap, while the sphincter can only be described as cruel, unusual, expensive, sadistic, and insane. Oh wait, I guess there really isn't a choice after all. Thank you.
So as I was wetting myself over there, I just wanted to think about a few things, and that was, the continence rates are excellent. I think I might choose a sphincter, and despite the fact that I have to kind of awkwardly press myself every once in a while to urinate, 95% satisfaction rate. I'll take those odds. Thanks.